Welcome to Practical Medicine. Today's topic is vomiting or emesis. Nausea and vomiting. Vomiting is also known as emesis in medical terms. What do you mean by nausea? Nausea is an unpleasant, greasy feeling in the throat or stomach that usually precedes the vomiting. And what is vomiting? Is a highly specific physical event that results in the rapid, forceful evacuation of gastric contents in retrograde manner from stomach up to the out of the mouth. So here vomiting, it is the forceful coming out of the gastric contents or maybe possible intestinal contents in retrograde manner from stomach up to the mouth or out of the mouth. It may be accompanied by tachycardia, hypersalivation, water breath and excessive perspiration. So these are changes that occur during the vomiting. Nausea and vomiting are considered chronic if they last for more than 1 month. If nausea and vomiting last for more than 1 month, then it is considered as chronic vomiting or chronic nausea. Now vomiting is associated with different type of other symptoms. For example, vomiting with weight loss, vomiting without weight loss, vomiting shortly after food, vomiting unrelated to food but with abdominal pain and fever, vomiting unrelated to food with abdominal pain but no fever, that means without fever, and non-metabolic causes of the vomiting, vomiting unrelated to food with abdominal pain but no fever, and this includes the metabolic type of causes of the vomiting, vomiting unrelated to food without abdominal pain but with headache, vomiting unrelated to food and without abdominal pain or headache. So basically we are going to see the differential diagnosis of all these types of vomiting that is associated with some other features. So first one, vomiting with weight loss. It is happening in the conditions of esophageal stricture. It is suggested by undigested solid food and fluid in the vomits, and there are symptoms of heartburn. It is confirmed by barium swallow, esophagogastroscopy that shows food residue and fixed narrowing of the tubes. Esophageal carcinoma. It is suggested by dysphagia to the solid food first, then semi-solid food and then finally fluid. So dysphagia occurs for the solid food first, later it is followed by semi-solid and finally fluid dysphagia occurs. It is confirmed by barium swallow that shows filling defect, and we have to advise or confirm this by fiber optic gastroscopy with biopsy of the tumor. Third one, gastric carcinoma. It is suggested by satiety after small meal. It is confirmed by the esophagogastroscopy that shows an allowing biopsy of the visible tumor as well as the barium meal that showing the filling defect. Small intestinal tumor, for example lymphoma, and it is suggested by abdominal pain, anorexia, bilious vomiting. Characteristic feature of small intestinal tumor lymphoma, bilious type of vomitus. It is confirmed by small bowel follow through the CT abdomen, flexible enteroscopy with the biopsy. Achalasia, and it is suggested by the vomiting after large meals, undigested solid foods are present as well as fluid is also present in the vomitus, and nocturnal regurgitation. It is confirmed by the barium swallow that is suggested by the absence of peristaltic contractions, esophagogastroscopy that shows the dilatation. So these all features we are finding the weight loss that is associated with the vomiting, or vomiting is associated with the weight loss. Now the second thing, vomiting without weight loss, esophagitis and ulceration. It is suggested by the retrosternal pain, heartburn, dyspepsia and water breath. It is confirmed by esophagogastroscopy that shows inflammation and or the ulceration of the esophagus. Pharyngeal pouch. It is suggested by there isn't any pain, regurgitation of the undigested food and aspiration, so that there is a conditions of aspiration pneumonia. It is confirmed by barium swallow that shows saccular opacification outside the pharynx. So that is the pharyngeal pouch. Next one, achalasia. Vomiting after large meals, undigested solid food and fluid material are present in the vomitus. Dysphagia to the fluid as well as nocturnal regurgitation. It is confirmed by barium swallow that demonstrates the absence of peristaltic contractions as well as esophagogastroscopy that shows the dilatation of the esophagus. So in conditions of achalasia, vomiting occur either with the weight loss or without the weight loss. Vomiting shortly after food, gastritis, peptic ulcer disease, duodenal ulcer or gastric ulcer. And this is suggested by vomiting during or soon after a meal. and there is also presence of epigastric pain as well as discomfort, and this epigastric pain or discomfort was after the food intake, and it is relieved by food that suggests the duodenal ulceration. That means if epigastric pain and discomfort is increased after food, then it is the suggested gastric ulceration, and if this epigastric discomfort or pain it is relieved by the food, then that suggests the duodenal ulceration. It is confirmed by esophagogastroscopy, barium meal and pH study. Any conditions that causes the gastric outlet obstruction, for example carcinoma, lymphoma, chronic scarring, congenital pyloric stenosis in the newborns. So it is suggested by intermittent vomiting more than 1 hour after eating. That means intermittent vomiting that occurs either equal to 1 hour or more than 1 hour after eating, abdominal fullness or bloating, distended upper part of the abdomen as well as suction splash. It is confirmed by the esophagogastroscopy and biopsy, double contrast barium meal that shows the structural abnormality. Small intestinal tumor, for example lymphoma, it is suggested by abdominal pain, anorexia, bilious vomits and weight loss. It is confirmed by the small bowel barium meal and that shows the filling defect, CT abdomen that shows the abnormal tumor in the wall, flexible enteroscopy with the biopsy that shows the abnormal histology of the intestinal mucosa. So that is the small intestinal tumor, for example lymphoma. Vomiting shortly after food, that is due to gastroparesis due to diabetes mellitus. It is suggested by intermittent vomiting that occurs more than 1 hour or equal to 1 hour after the food intake or eating. It is associated with the abdominal fullness or bloating, and it causes the distension of the upper part of the abdomen, suction splash as well as history of the diabetes is also present. It is confirmed by the gastroenteroscopy, double contrast barium meal that shows the normal mucosa but with dilatation. So that is the gastroparesis that is due to diabetes mellitus. Acute cholecystitis that is due to cholelithiasis. It is suggested by nausea and vomiting after fatty food, specifically fatty food, with colicky abdominal pain. It is also associated with the tenderness in the right upper quadrant or Murphy's sign positive or the jaundice. So that is specifically acute cholecystitis that is due to cholelithiasis, and it is suggested by the nausea and vomiting after fatty food. Typically after fatty food the person experiences the nausea and vomiting. It is associated with the colicky abdominal pain as well as tenderness in the right upper quadrant or the Murphy's sign is positive, and we also found jaundice in them. It is confirmed by ultrasonography scan of biliary tree and gallbladder that shows the stones, gallbladder stones. Acute pancreatitis. It is suggested by severe epigastric central abdominal pain that is associated with the jaundice feature, tachycardia, Cullen sign, that means there is presence of paleoumbilical discoloration, or Gray Turner sign, that means discoloration of the flank. And it is confirmed by there is high increase in the serum amylase level along with decrease in the calcium level, as well as we can also advise CT pancreas. Vomiting with abdominal pain and fever, that means vomiting plus abdominal pain plus fever. So the first thing, gastroenteritis from live microbes, for example salmonella. It is suggested by the diarrhea, increase in the bowel sounds, and it is confirmed by stool for culture for the S. typhi. Second one, food poisoning from the toxins of the dead microbes, for example staphylococci. It is suggested by vomiting that occurs within the hours of ingestion, that is associated with the diarrhea, and there are the associated peoples are also affected. It is confirmed by stool for WBC, culture of the vomits, food and blood are negative. We find the staphylococci in the food but not in the blood. Urinary tract infection, for example pyelonephritis, in this condition it is followed by or the suggested by dysuria, frequency increased, dipstick indicating of the blood as well as protein and nitrates in the urine. And all these features are present if there is a gram negative infection is there. It is confirmed by MSU microscopy. What is MSU? Midstream specimen of the urine, as well as we also confirm by the US scan that shows the anatomical abnormality. Acute appendicitis, there is presence of right lower quadrant pain that is associated with the anorexia, nausea and vomiting. It is confirmed by tenderness at the McBurney's point, guarding, rebound or right-sided rectal tenderness is present. And we can also confirm by investigations like US, that means ultrasonography of the appendix, or the spiral CT scan. Mesenteric adenitis or non-specific abdominal pain, NSAP, that is suggested by there is presence of pain in the right lower quadrant of the abdomen associated with the anorexia and fever. And it is confirmed by, that means there is presence of diffuse right lower quadrant tenderness, no guarding, no rebound, no right side rectal tenderness, and it is the self-limiting type of outcome. So that is the mesenteric adenitis or the non-specific abdominal pain, and all these are the features as well as the confirmation procedures. Vomiting with abdominal pain and fever. Hepatitis A or B, it is suggested by right upper quadrant pain and jaundice, and it is confirmed by increase in the ALT, that means alanine transaminase, increased bilirubin, and hepatitis serology. Toxic shock syndrome, it is suggested by history of tampon use, nasal packaging, and it is associated with the high fever, vomiting, profuse watery diarrhea, confusion, skin rash, hypotension, myalgia. There is presence of increase in the white cell count and decrease in the platelet count on the full blood count report, and there is increase in the creatine phosphokinase. It is confirmed by culture of the blood, stool, vaginal swab for the staphylococcus and toxins. Pneumonia, specifically of the lower lobe, that is associated with the vomiting, abdominal pain and fever. It is suggested by the productive cough, dyspnea, fever and increase in the white cell count. It is confirmed by the chest x-ray that shows the consolidation, and we also confirm it by the sputum and blood cultures, serology if there is presence of a typical type of pneumonia. Pelvic inflammatory disease, that is suggested by the lower abdominal pain, fever, vaginal discharge, and it is confirmed by high vaginal swab, increase in the ESR and CRP levels, and full blood count that shows the leukocytosis. We can also confirm it by the pelvic US scan plus or minus laparoscopy. Vomiting with abdominal pain and fever, the hemolytic uremic syndrome. It is suggested by diarrhea, irritability, seizures, confusion as well as gastrointestinal bleed and hematuria. And it is confirmed by the full blood count that shows thrombocytopenia, that means decrease in the platelet count, fragmented RBC on blood film and renal failure. And on urine and electrolyte examination we found the features of renal failure. So that is typically the hemolytic uremic syndrome. Malaria, that is Plasmodium vivax, Plasmodium ovale, P. malari, P. knowlesi and P. falciparum. It is suggested by the recent travel to malaria zone, periodic paroxysms of the rigors, fevers, sweating and nausea. So that is the typical symptoms of the malaria, that is rigors, fever and sweating. It is confirmed by the Plasmodium in the blood smear. So all these are the conditions in which we found the vomiting that is associated with the abdominal pain and fever. Vomiting with abdominal pain alone, that means without fever, and here we are seeing only non-metabolic causes, and these conditions include large bowel obstructions, for example malignancy, strangulated hernia. It is suggested by the fecal vomiting and abdominal distension. It is confirmed by the abdominal x-ray that shows the bowel dilatation, barium enema and colonoscopy. Hepatic carcinoma, first degree or second degree. It is suggested by the right upper quadrant pain and mass, and there is presence of features of jaundice. It is confirmed by weight loss over weeks to months. There is increase in the alpha fetoprotein levels, US scan, CT scan or MRI of the liver that shows the hepatic mass. These all are the features as well as the confirmation of the hepatic carcinoma first or second degree. Mesenteric artery occlusion, it is suggested by the wasting, periumbilical pain, specifically the postprandial periumbilical pain, phagophobia, diarrhea, melena and absent bowel sounds. It is confirmed by the CT abdomen mesenteric angiography that shows the filling defect. Renal calculi or the renal stone, it is suggested by the colicky loin pain and hematuria. It is confirmed by the plain abdominal x-ray, US scan, abdominopelvic CT scan, intravenous urography. Next one, vomiting that is associated with the abdominal pain only and non-metabolic causes. Ectopic pregnancy, miscarriage that is suggested by the cramping type of pain, spotting or per vaginal bleeding. It is confirmed by the positive pregnancy test and US scan of the pelvis. Acute inferior myocardial infarction, it is suggested by the central chest pain, sweating and nausea, and it is confirmed by the increase in the CT or decrease in the T wave on the ECG, and that is associated with the increase in cardiac enzyme, for example creatine kinase, myocardial band, CKMB or the troponin. congestive cardiac failure and liver congestion, that is suggested by the dyspnea, orthopnea, PND, that means paroxysmal nocturnal dyspnea, liver enlargement and tenderness, as well as leg edema. It is confirmed by the chest X-ray and echocardiogram. In all these conditions, we found the vomiting that is associated with the abdominal pain only, and all these are the non-metabolic causes of the vomiting. Next, vomiting with abdominal pain alone, and it includes the metabolic causes. It is suggested by the history of drug ingestion digoxin, and it is confirmed by the increase in the serum digoxin level. Diabetic ketoacidosis, that is suggested by the polyuria, dehydration, and there is presence of Kussmaul type of respiration, and it is confirmed by the increase in blood glucose level, decrease in the pH level, as well as there is presence of ketonemia or ketouria. There is decrease in the plasma bicarbonate level less than 15 millimole per liter. So all these conditions and confirmations give to the diagnosis of the diabetic ketoacidosis. It is associated with vomiting with abdominal pain, and it includes the metabolic causes. Hypercalcemia, it is suggested by the lethargy, confusion, constipation, muscle weakness, polydipsia, and polyuria. And it is confirmed by the highly increased serum calcium levels. Next one, Addison's disease. It is suggested by the lethargy, weakness, dizziness, pigmentation, buccal or scar mark is present, and hypotension. We can give the confirmation if there is decrease in the morning 9 am plasma cortisol level, and it is associated with the impaired response to short synchrotron test. Acute intermittent porphyria, it is suggested by the LFT, that means liver function test, peripheral neuropathy, constipation, hypertension, psychosis, and the urine becomes dark after the standing. That means on standing position, if the urination has been done, then the urine will be converted to the dark. It is confirmed by the increase in the urinary aminolevulinic acid and porphobilinogen plasma porphyrins. Next, causes vomiting plus abdominal pain and metabolic causes. Pheochromocytoma, that is suggested by the headache, sweating, palpitations, pallor, nausea, hypertension, and it is associated with the intermittent or persistent hypertension and tachycardia. It is confirmed by increase in the 24-hour urinary metanephrines, increase in the serum catecholamines, adrenaline and noradrenaline, as well as we can also suggest CT abdomen and MRI scan for the final confirmation. So this condition is pheochromocytoma. Lead poisoning, it is suggested by anorexia, personality changes, headache, the taste sensation becomes metallic and loss of sensation. It is confirmed by increase in the whole blood lead concentration, that is more than 2.4 micromole per liter. Vitamin A intoxication, and it is suggested by increased intracranial pressure, drowsiness, headache, irritability, muscle pain and weakness. And it is confirmed by symptoms and signs that go within 1 to 4 weeks after stopping vitamin A injection. If we stop the vitamin A injection, then the symptoms and signs will go away within 1 to 4 weeks. So all these are the conditions in which vomiting is associated with the abdominal pain, and these are all metabolic causes. Next condition, vomiting unrelated to food without abdominal pain but with headache. That means vomiting and headache that is not associated with the food intake or abdominal pain, and this includes the migraine. It is suggested by the throbbing headache with preceding visual auras or other transient sensory symptoms, and there are some triggering factors, for example premenstrual, stress or foods. It is confirmed by the history taking, and we can also advise the MRI scan to exclude anatomical abnormalities. Raised intracranial pressure, that is worse in the morning on coughing and leaning forward, that is associated with the papilloedema, pupillary dilatation, bradycardia and increased pulse pressure. It is confirmed by the CT scan of the head that shows fluttering of the sulci and darkening of the brain tissues. So that is typically the features of the raised intracranial pressure associated with vomiting and headache. Meningitis, viral or bacterial. It is suggested by the photophobia and associated with the fever, neck stiffness and Kernig's sign, and Brudzinski's sign is present. And in conditions of meningitis, if we advise CT scan, then there is no any signs of increase in the intracranial pressure we are going to note. But on lumbar puncture, in conditions of viral, there is increase in the lymphocytes with normal glucose level, but in conditions of bacterial, there is increase in the neutrophil as well as decrease in the glucose level. And we can also confirm by staining and cultures if there is origin is bacterial. So this is typically the meningitis that is associated with the vomiting and headache. Hemorrhagic stroke, it is suggested by sudden onset of the headache. Then hemiparesis is followed, but not the upper face. That means the half of the body having the muscle weakness, but not on the upper part of the face. It is associated with the dysarthria, dysphagia, and extensor plantar response. It is confirmed by the CT brain that shows high attenuation area representing the hemorrhage. So typically it is the hemorrhagic stroke. And all these conditions are associated with the vomiting and headache. If we find vomiting and headache and all these type of features, then we can differentiate specific disease. Severe hypertension, that is suggested by continuous throbbing headache. Non-severe hypertension is usually asymptomatic. Typically the severe hypertension, it is suggested by continuous throbbing headache. But if the non-severe type of hypertension, there isn't any symptoms. And headache is associated with the visual disturbances and papilloedema in malignant hypertension. It is confirmed by the serial blood pressure measurement, usually more than 140 mmHg diastolic and or all more than 240 mmHg systolic blood pressure. When this blood pressure recorded on subsequent reading, then we can go on the confirmation that the patient having the severe type of hypertension. Acute glaucoma, that is suggested by blurred vision, painful red eye and colored halos. It is confirmed by increase in the intraocular pressure on the measurement. So that is typically the acute glaucoma. Idiopathic epilepsy or secondary to brain tumor or cerebrovascular disease or acute hypotension or metabolic disturbances, specifically epilepsy. It is suggested by the aura, altered consciousness and abnormal movements, and it is confirmed by the electroencephalogram result. So that is the vomit that is associated with the headache but not associated with the food intake or abdominal pain. Vomiting that is unrelated to food, without abdominal pain and without headache, only vomiting. So these conditions include gastroenteritis that is suggested by the diarrhea and increased bowel sounds, and there is presence of stool for WBC and culture. Second condition, acute viral labyrinthitis. It is suggested by the vertigo, tinnitus, hearing loss and nystagmus. It is confirmed by the being dehydrated over days. Drugs, for example antibiotics, cytotoxics, metformin, any overdose, excessive alcohol ingestion, all this suggested by the history of drug ingestion, vomiting and soon after taking medications. That means the vomiting occur after taking the medication. It is confirmed by the response of symptoms to avoidance of the causative drug. That means if we can stop the drug, then symptoms will become resolved, vomiting becomes stops. It's related to the drug ingestion. Sliding hiatus hernia, that is associated with the occasional chest pain precipitated by the heavy meals and lying flat. It is confirmed by the barium meal that shows the reflux, and we can also advise endoscopy. Chronic renal failure, that is suggested by the fatigue, pruritus, anorexia, nausea, lemon tint skin, and it is confirmed by the high serum creatinine, low creatinine clearance or the eGFR. And if this chronic renal failure, there is also decrease in the hemoglobin level, and we can also found small kidney on renal US scan. So that is typically chronic renal failure. Pregnancy, hypermemesis gravidarum, and in this vomiting worse soon after waking, but the woman will feel better after some time, and there is presence of amenorrhea less than 3 months, and it is confirmed by pregnancy test positive. That means the woman is pregnant. So that is the pregnancy hypermemesis gravidarum. So in these conditions, the vomiting is not associated with the food intake, abdominal pain or headache. Furthermore, the vomiting without food intake, without abdominal pain, without headache, only vomiting. This includes the Meniere's disease that is suggested by the vertigo, tinnitus and deafness. On audiometry we found sensory hearing loss. Acute otitis media in children, it is suggested by fever, earache, decreased hearing. If the eardrum is perforated, then we also found the otorrhea, and it is accompanied with the upper respiratory infection symptoms. It is confirmed by the otoscopy or tympanometry. Anaphylaxis, it is suggested by the bronchospasm, laryngeal edema, flushing, urticaria and angioedema. It is confirmed by relief with antihistamines or steroids. Addison's disease, there is presence of lethargy, weakness, dizziness, pigmentation, either buccal or scar mark, as well as hypotension. If we find decrease in the 9 AM plasma cortisol level and impaired response to short syncytin test, then we can give the confirmation that it's a Addison's disease, or the vomiting is associated with the Addison's disease. Functional vomiting. It is suggested by the vomiting during or soon after a meal, other psychological disturbances, and no symptoms and physical signs of the organic disease. It is confirmed by response to psychotherapy, that is typically the psychological, and some other causes of the vomiting that is not associated with food, abdominal pain or headache, that is the diabetic gastroparesis, intracranial pressure, esophageal or pyloric obstruction, any viral or bacterial infection. So in all these conditions we found only vomiting, without food intake, without abdominal pain, without headache. I hope now you understand vomiting and its differential diagnosis. If you like this presentation, please try to share it with your friends, group, batch and colleagues. Thank you so much everyone.